First of all, I would like to thank Global Health Academy for their kind invitation, and I would like to welcome everyone with us today. My job over the next 20 minutes or so is to share with you our recent collaborative research in SOPA and discuss with you our recommendations, practical strategies to manage cancer patients during the current pandemic. And I would like to take this opportunity and thank all of my colleagues, my co-authors in this paper, for their great and tremendous effort in writing these recommendations. Actually, our paper got published on last May in the Journal of Oncology Pharmacy Practice, which is the official journal of ISOP, or the International Society of Oncology Pharmacy Practitioners. Just to give the audience idea about this project, actually the idea was generated and discussed back in last April, where we had the peak of COVID-19 here in Saudi Arabia, where a group of oncology pharmacy practitioners, we were around 12 pharmacists, we discussed and we came up with this idea to write recommendations about the management of cancer patients during the COVID-19. We came up with 8 practical strategies to reduce cancer patient visits to their cancer centers in order to minimize the risk of exposure to COVID-19 infections. So this paper actually is available to everyone. I highly recommend everyone involved in managing cancer patients to access this paper. This paper was published in open access format, so everyone can download this recommendations and read them thoroughly. So this is my disclosure. I have nothing to disclose today. As all we know that COVID-19 has become a public health crisis locally and internationally until this moment, and we know that cancer patients are considered one of the most vulnerable group of patients to COVID-19. So cancer patients are known to, or tend to have a severe COVID-19, and this is based on the recent studies that we get from all over the globe. So those patients are at risk of severe infections because they tend to have comorbidities, advanced stage, poor performance status, as well as these group of patients, they usually receive a very toxic kind of treatment, and they usually have immunosuppressed system. So it's really important to take care of those patients and try to minimize the risk of having the COVID-19 infections. In the early reports on early statistics, the mortality rate from COVID-19 in cancer patients were around 6%, but unfortunately, the early statistics were not accurate. And according to many studies published recently, and based on the experience that we get from the United States, where they have huge number of cancer patients, around 28% as mortality or fatality rate were reported in cancer patients compared to non-cancer patients. This, again, the risk factors for COVID-19 in cancer patients. Again, those patients, they have immunosuppressive states caused by either malignancy itself or the cancer treatment complications. Those patients, usually elderly patients, and they have poor organ dysfunctions, or they have multiple comorbidities that may lead to more kind of toxicities from the chemotherapy itself, or the complication of COVID-19 infection. So before discussing our SOPA recommendations, I would like to highlight some important measures, which are the first, we have the hospitals or the cancer centers should apply the multidisciplinary approach to manage their cancer patients, and they should have very open communications among the healthcare providers, as well as conveying these or maintaining these open communications with our patients. The second important principle is that oncologists or oncology physicians should assess the benefit versus the risk from the cancer treatment. So they have to assess the benefit of chemotherapy versus the risk of disease progressions, and this should be discussed with cancer patients in fair and transparent manner. As a response to the COVID-19, most of the oncology societies and organizations in the beginning, they were very active, and they published like a good number of guidance for oncologists to manage cancer patients during the COVID-19 infection. And they stressed on the importance of, again, of keeping open communication between administrators, staff, and patients, as well as the general public. And in addition to that, like NCCN guidelines recommend to create an incident command structure to provide an early coordination of institution-wide efforts to respond to these changes, which is very quick changes actually. And the last important point, they highlighted that there is a need to be flexible and to accept all unexpected changes from the COVID-19. I think most of the centers here in Saudi Arabia also did a great job in managing those patients. I mean, in prioritizing the, like for example, prioritizing the admissions, managing patients who received like curable chemotherapy, and they were actually they managed to get like good outcomes and to prevent the high mortality associated with COVID-19 infections. So now we'll move to the most important part of my presentation today, which is the practical strategies that we proposed in SOPA. So again, this project was, the idea was generated in April 2020 during the peak of COVID-19. We were aiming to reduce the frequency of cancer patient visits to oncology centers during the pandemic while maintaining the access to cancer therapy and minimize the risk of exposure to coronavirus. Our method, it was a qualitative methodological approach, was again conducted in April 2020 using a virtual panel discussion for collection of the recommendations. A total of 12 expert oncology pharmacy practitioners shared their knowledge and experience in managing the COVID-19 cancer patients. They participated with their center's experience, with their knowledge, and we collected the evidence that already applied in different centers here in Saudi Arabia or in the international cancer centers, and we came up with 8 practical recommendations. The first recommendation was that we propose is to delay the adjuvant chemotherapy in solid tumors. We know that the adjuvant chemotherapy is very commonly used in solid tumors, and the adjuvant chemotherapy is associated with major improvement in the cancer-related outcomes. I mean, progression-free survival, the disease recurrence, and as well as the overall survival. So the first recommendation is to delay adjuvant chemotherapy within the acceptable range of initiation. So in breast cancer, for example, we know that the window to start adjuvant chemotherapy is up to 3 months or 12 weeks, but we excluded actually triple negative breast cancer, which they tend to have more kind of aggressive, and usually their disease is highly aggressive, and those patients usually associated with low survival rate. In addition to that, ISMO guidelines recommended to exclude HER2-positive patients. We know that HER2-positive breast cancer, which is representing around 30% of breast cancer, we should not delay their adjuvant treatment, and we should offer them the best available option to ensure the best outcomes. In addition to breast cancer, we have recommended that in colorectal cancer and gastric cancer, we can delay the adjuvant chemotherapy till 8 weeks in both diseases. The second important recommendations that we propose is to use the extended schedule for cancer therapy, and we have listed a couple of examples. The first example is to delay or to utilize the new dosing strategies of immune checkpoint inhibitors. We know that nivolumab initially granted the FDA approval back in 2018 to be used every month with the dosing of 480 milligram. And the pembrolizumab, luckily, we got the approval in, I guess, in May or in April 2020, and we started actually to apply this in our center. And I think many centers in Saudi Arabia and internationally started to use the extended dosing strategies of immune checkpoint, both pembrolizumab and nivolumab. Pembrolizumab can be used as a 400 milligram every 6 weeks, while nivolumab is 480 monthly. The other recommendations or other example is to use the every 3 weeks regimen of taxanes. We know that taxanes are considered a backbone of treatment, backbone of most of the chemotherapy in breast cancer patients in all subtypes. We have recommended to use like paclitaxel and docetaxel as every 3 weeks regimen. In addition to chemotherapy in breast cancer patients, we use bone-modifying agents. We have recommended to use the monthly bone-modifying agents, both zoledronic acid as well as denosumab for bone metastases. And the last example is to use the LHRH agonist in both breast and prostate cancer. And we have recommended to use the 3 months or 6 months injections. The third recommendation was to switch from IV chemotherapy to either oral or subcutaneous route of administrations. We have recommended to shift most of the patients on either etoposide, cyclophosphamide, or other chemotherapy with high availability. We recommended to switch those patients to oral forms and to replace 5-FU with oral Xeloda or oral capecitabine. And the last example is to utilize the subcutaneous route of administrations for all biological agents that granted the FDA approval, such as rituximab, trastuzumab, or daratumumab in multiple myeloma. The fourth recommendation, sorry for this busy slides, the administration of both chemotherapy and supportive care medications at home. We have recommended that if the centers, and I think this is not easy to apply, I mean the use or administration of chemotherapy in at-home settings, we have recommended that if the hospitals can provide, like if they have good facility and they can like send nurses to a patient's home to administer some types of chemotherapy, such as the subcutaneous chemotherapeutic agents. And we have given good examples, such as azacitidine for AML and MDS patients, pertuzumab for multiple myeloma, and subcutaneous trastuzumab, or even subcutaneous rituximab at home setting. We have also recommended to use, to administer some of types of chemotherapy which are commonly prescribed in as IV Bosch, such as zinc alkaloids at home. Again, this recommendations is not easy to apply, but I think many centers outside our country started to apply this concept and start to administer chemotherapy at home setting. The other, I think, other options which is more easy to apply is to administer supportive care medications at home, such as IV antibiotics. Some types of hydrations can be also administered safely at home without affecting the patient's outcomes. The fifth recommendations was about the stem cell transplantation. We know that stem cell transplant, sometimes it's the only options for acute leukemia patients or other hematological malignancies. It's not easy to delay this important kind of treatment, but the ASPMT and EPMT, they have written very nice guidance for patients, for those patients, and to overcome or to decrease risk of COVID-19. So they stated that if the patient's disease risk allows, for example, those patients with multiple myeloma or patients with low-grade lymphomas where the risk of disease recurrence or disease progression is low, they can postpone all procedures related to transplant. But if the patients need to be transplanted, you have to admit those patients, and you should like follow certain procedures to make sure that this patient should get proper screening, proper assessments, and they should be monitored and get very good kind of monitoring during their hospital stay to prevent them from getting the COVID-19. The sixth recommendation was about the intermittent use of chemotherapy and treatment discontinuation for some types of the cancers. We know that chemotherapy play a major role in early disease for most of the solid tumors, but in metastatic settings where your patients have a kind of palliative chemotherapy, patients can be offered what's known as chemotherapy holidays, especially in this time, during the pandemic. We can like delay a couple of weeks. We can switch patients from aggressive kind of chemotherapy to less aggressive. We can interrupt the treatment for a couple of weeks, especially those patients who is on chemotherapy for a long period of time and they showed like stable kind of disease. So we can interrupt the chemotherapy and offer them kind of holidays. The other important example is discontinuation of chemotherapy or oral chemotherapy, especially in patients with chronic myeloid leukemia who achieved and maintained major molecular responses with careful monitoring. And this practice actually was started a couple of years ago. We know that those patients, they survive for a long period of time with a specific criteria proposed by, for example, it's in NCCN guidelines. We can stop the oral TKIs safely in this group of patients. The seventh recommendation was related to our pharmaceutical care services. We need to activate telemedicine to manage those patients, but in both clinic and in pharmacy for managing cancer patients who are prescribed or oral chemotherapy agents. We have listed very good number of examples in same-male patients in lung cancer who prescribed tyrosine kinase inhibitors, EGFR inhibitors. Those patients are usually stable patients, and they can be managed by like a virtual approach through using the telephone or the other online services. So we highly recommend those patients not to come to the hospital because they are stable and can be managed safely through the telemedicine approach. The last recommendation, which is using or applying some innovative ideas to minimize patients' visits to pharmacy by either sending the medications by postal carriers to patients' homes or using the drive-through function for those patients to collect their medications. And I think most of the hospitals applied this concept because it's easy to avoid the visit of those patients to the crowded pharmacy waiting area. And I think most of the hospital did a great job in providing this kind of services. The other options that we have recommended is to have a kind of collaboration between the pharmacy, especially pharmacy departments, and in the kingdom. We have heard from our colleagues from different hospitals. They had a good experience and good communication, for example, between Jeddah and Riyadh, Jeddah and Jazan, Jeddah and the North region. We communicated with our colleagues in those regions, and we sent them our plans for our patients. For example, if you have a patient on, for example, maintenance trastuzumab, breast cancer on maintenance trastuzumab, those patients can be easily managed in their areas. For example, if you have a patient from Al Medina and he's getting their treatment here in Jeddah, we can send them safely to that centers, even if they have like some limited resources. We can provide them with the medication, with the whole treatment plan for those patients. The last important point is to have, again, open communication with those patients by activation of 24 hours hotline and on-call services run by oncology pharmacists for consultation and inquiries related to their treatment. So to conclude my presentation today, I would like to say that delivering cancer patients during COVID-19 was not easy. It was a challenge for most of the centers here in Saudi Arabia. Our paper addressed some practical strategies which were based on strong evidence in the literature. Implementing these changes are really important in both national and international levels. These recommendations will guarantee the quality and the continuity of care. And the last point is that SOPA experts develop these recommendations to ultimately contribute to in maintaining the access to cancer therapy while minimizing the risk of COVID-19 exposures in cancer patients. With this slide, I would like to conclude my presentation today, and thank you so much.